As all of us know, the heart failure management trial have started from 1986, from the first trial which was done called VHAF trial, which was done on isolazine and hydralazine molecule. Now after that, subsequently there are many new molecules have been added in our armamentarium of heart failure management. In 1987, consensus trial was there, then there was a SOLVE trial which was done on enalapril in 1991. So like that, beta blockers were introduced in 1999 when the MERIT HF trial, CVS2 trial for bisoprolol actually got the approval for treatment in heart failure. Similarly, other trials like RAILS trial was done on aldactone in 1999. Followed after that, the aldactone was used as a treatment for the heart failure. After that, from 2000, there were other molecules which were there, like valsartan, which was proven in the VALHAF trial. Then there was a trial like companion trial. Then there was trial like CARE-HF trial for the carvedilol. So with the every passing year, there were some new molecules which were added in each decade. But if you see the molecule compared to the previous years, where new molecules like beta blockers, aldactone, and mineralocorticoid receptor antagonists like aldactone, and then AC inhibitors, ARBs were invented, then there was a gap from almost 2005 to 2019 where there were not significant discoveries of molecules were found. So during this time, actually few of the interesting trials were there, like MERIT CRT trial, HeartMate trial, SIFT trial. These trials were done on heart failure patients for device therapies like AICD implantation, CRTD implantation, or surgical restoration of LV in those patients who have a very dilated LV for heart failure. So these trials have shown that we have there are other options for treating heart failure patients like implantation of CRTD and AICD, but only very few patients actually qualifies to get CRTD, and again cost is a very big factor in India. Plus only the heart failure patients who have a LBBB and a wide QRS complex actually ultimately gets benefit from implantation of CRTD. So that only 10 to 15% patients usually have this kind of electrical activation problem. So that is why the medication remains the most cornerstone or most important treatment for the heart failure. So after that, if we see after the beta blocker, then there was a gap of almost 10 years. After that, actually there was a new molecule which has come, that is called ARNI, and it has almost revolutionized our treatment in heart failure because of its robust result compared to the previous molecules like AC inhibitor or ARBs. And after that, then again there was a new molecule called SGLT2 inhibitor, which have again added much benefit from the existing treatment of heart failure. It has been found that ARNI actually increases the survival in patients of heart failure, reduced ejection fraction compared to enalapril in Paradigm HF trial. It was a landmark trial. It has shown that ARNI has a much superior result compared to enalapril on head-on comparison in a randomized trial, and it has got a much safer profile compared to enalapril because it causes lesser hyperkalemia, lesser incidence of hypotension. It was a better tolerated molecule compared to enalapril. So after that, the guideline have changed, and it has been found that ARNI now become the first line of management for heart failure compared to enalapril. Now, all these trials, like whether beta blocker, aldosterone antagonist, hydralazine nitrates, or AC inhibitor ARB, these actually causes relative mortality risk reduction in the tune from 15% to 30%. Now, ARNI, when it is added above all these guideline-directed medical therapy, it has a potential to decrease the mortality by almost 20%, which is an incremental benefit compared to the other molecules. So NYHA class changes after the introduction of ARNI is also very robust because clinical improvement also results in a superior quality of life with ARNI compared to enalapril. So these are important effects of ARNI compared to enalapril.